знакомимся. Все,
Все работает.
сюда можно писать им, да, если
А вы
что.
можете говорить, они будут писать.
Я понял, хорошо. Всё, спасибо. Hello everyone. Today's topic is thyroid tumors. So you can see the normal anatomy of the thyroid gland and all vein and arteries and innervation. So you can see here the microscopic picture of the thyroid gland. So there is the thyroid follicle and colloid part of it. And you can see it more closer. So colloid, parafollicular cells and principal cells. Types of thyroid cancer. The primary cancer is the follicular epithelium, well differentiated, papular follicular. Follicular epithelium undifferentiated, anaplastic. Parafollicular cells, it's medullary cells. Lymphoid cells, so you can know the lymphoma. And secondary type of thyroid cancer is metastatic cancer. Causes of the thyroid cancer. Radiation exposure to thyroid gland in childhood. The genetic part, 4 to 10-fold increased risk of well-differentiated thyroid cancer in first-degree relatives with this neoplasia. Next cause is the iodine. Iodine deficient diets may lead to increase the thyroid TSH level, thyroid stimulation hormone, causes the thyroid gland to make two hormones, T3 and T4, thyroidine and thyroxine. The 3 and T4 help control your body metabolism and considered diuretic. Thyroiditis, Hashimoto disease, may be developed into a form of cancer called lymphoma. T categories for thyroid cancer other than anaplastic thyroid cancer. So you can see, you can make picture. So Tx, primary tumor cannot be assessed. T0, no evidence of primary tumor. T1, the tumor is 2 centimeters, slightly less than an inch, across or smaller than, and has not grown out of the thyroid. T1a form, the tumor is 1 centimeter, less than half an inch, across or smaller than, has not grown outside of the thyroid gland. T1b, the tumor is larger than 1 centimeter but not larger than 2 centimeters across and has not grown outside the thyroid. T2, the tumor is between 2 and 4 centimeters, slightly less than 2 inches across and has not grown out of the thyroid. T3, the tumor is larger than 4 centimeters or it has began to grow a small amount into nerval tissues outside the thyroid. So, if the tumor could be 1 centimeter but still grow outside the thyroid, it will be T3 form. T4A, the tumor is any size and has grown extensively beyond the thyroid gland into nerval tissues of the neck, such as larynx, voice box, trachea, esophagus, connecting the throat to the stomach, or the nerve at the lungs. This is also called moderately advanced disease. T4B, a tumor of any size that has grown either back toward the spine or into nearly large blood vessels. This is also called a very advanced disease. Coming up next, T categories for anaplastic thyroid cancer. All anaplastic thyroid cancers are considered T4 tumors at the time of diagnosis. T4A tumor is still within the thyroid. T4B tumor has grown outside of the thyroid. And categories for thyroid cancer. N-X lymph nodes cannot be assessed. N0, no spread to neighboring lymphoma nodes. N1, the cancer has spread to neighboring lymph nodes. N1A, spread to lymph nodes around the thyroid in the neck, called pretracheal, paratracheal, and prelaryngeal lymph nodes. N1B, spread to other lymph nodes in the neck, called cervical, or to the lymph nodes behind the throat, retropharyngeal, or in the upper chest, superior-mediastinal lymph nodes. M categories for thyroid cancer. M0, no distant metastatic. M1, spread to other parts of the body such as distant lymph nodes, internal organs, bones, and etc. So here you can see 6th edition of the AJCC or UICC staging, popular and follicular carcinoma. Very important part of the staging due to age. So you can see there are two big groups of staging: the age under 45 years and age above 45 years and older. And here is the staging for medullary thyroid carcinoma. And here you can see the staging for anaplastic carcinomas. They all four staging. Evolution of thyroid tumor. So history, age and gender, rapid increase in size, sneer, dysphagia and heredity of voice family, history disease of thyroid cancer, history disease of irradiation. On examination, fineness, mobility, size and adherence to surrounding structures. Present on lymphadenopathy. Investigations which would be useful in putting back diagnosis. If an AC, it's fine node aspiration biopsy. US ultrasound. So fine needle aspiration histology or biopsy, the range from 70 to 97% and highly dependent at accuracy cytological diagnosis from fine nodular aspiration, the skill of the physician and the symptomatologist interpreting it. Ultrasound for the presence of the malignant associations, microcalcifications, regular emergence, hypervascularity, extragranular extension. Also, we can combine such investigations. So it's ultrasound guiding fine needle aspiration biopsy. decrease the non-diagnostic specimen, increase the sensitivity and specificity, avoiding vascular structures. Radionuclide scan to determine the functional status of the node, hypofunctional cold node. Serum calcification level, routine measurement of calcium level advocated by some authors of medullary cancer. So, the popular thyroid cancer, cystic or solid, most common, 80 or 85% of all thyroid cancers, spread through lymphatic system. History of disease, female to male is 3 to 1. So popular cancer, the histological view. You can see it here. You can see empty nucleus here. The picture is not so well, but you probably can see it. So clinical presentation. Incidental, a small acute tumor less than 1 centimeter, papillary microcarcinoma. Mass in the neck, the commonest way papillary carcinoma presents. Glands in the side of the neck, the spread to local glands, sometimes called erinaceously. Lateral aberrant thyroid. Distant spread to lungs or bone is very rare, but when it occurs, unlike most other cancers, cure is possible. The follicular cancer. It is an unfocal, thickly encapsulated and shows invasion of both capsule and blood vessels, spread by the bloodstream and rarely through lymphatic system. It is unusual tumor. It occurs from 5 to 10% from all thyroid cancers. Clinical presentation. It presents as a single lymph in the thyroid. This is the common mode of presentation. As pain in a bone or spontaneous fracture. Cause of metastasis to bone through the bloodstream. So you can see here the statistic of papillary and follicular cancer. As we can see here, the distance metastasis for papillary cancer is 45% and for follicular cancer is 75%. The prognosis in differentiated thyroid carcinoma. The two dominant factors are the age at the diagnosis and the presence of distant metastasis. Recent serial scoring systems based on multifactorial analysis of risk factors have been advised. So you can see here the comparison of 7 different prognostic classification systems in well-differentiated thyroid carcinoma. Now you can see the table about the risks, low risk and high risks. So with what we can see here, the patient age 45s and lower, 45s and up. Tumor size less than 4 cm, more than 4 cm. External extension, absent, present. Distant metastatic, absent, present. High tumor grade, absent, present. So, if we have one of these risks, then let's talk about the treatment of well-differentiated tumor cancer. So, like all types of cancers consist of three branched attacks: thyroid surgery, radioactive iodine therapy, and drug thyroxine therapy. Surgery. Acceptable surgical procedure to remove thyroid tumor include ipsilateral lobectomy of thyroid gland, near total thyroidectomy, total thyroidectomy. The recent American Thyroid Association guidelines recommended for more aggressive total thyroidectomy for well-differentiated thyroid carcinoma. Arguments for total thyroidectomy in well-differentiated thyroid carcinoma. So it will be high survival rate for lesions, 1/2 cm in diameter, lowest recurrent rate in all patients, prevention for recurrence in the contralateral lobe, reduce the risk of developing pulmonary metastasis, can be performed with the same morbidity as thyroid lobectomy. Improve sensitivity of serum thyroid globulin as a marker for presence of recurrent disease. Radioactive iodine can be used to detect and treat persistent or recurrent disease. Reduced possibility of residual tumor in contralateral lobe, undergrounding transformation to neoplastic carcinoma. With 20-year follow-up, the incidence of local recurrence with unilateral resection was 14%, whereas for bilateral resection it was only 2%. For gross involvement of trachea esophagus resection of this structure with reconstruction. So, radioiodine therapy. After surgery to destroy any residual thyroid cancer cell or residual normal thyroid tissue. to treat thyroid cancer that has spread to the lymph nodes, lungs, or bones. To treat thyroid cancer recurrence after initial treatment by surgery or previous radioactive iodine overload. So, radioiodine therapy. Recent American Thyroid Association guidelines recommended radioiodine ablation for stage 3 or 4 disease, all patients with stage 2 disease less than 45 years or more than 45 years. Selected patients with stage 1 disease, those with large tumors more than 1.5 centimeter, multifocality, residual disease, and nodal metastasis. Thyroxine therapy. Recent meta-analysis supported to the effectivity of TSH suppression in preventing adverse clinical effect. High-risk patients are maintained a TSH level below 0.1 and low-risk patient TSH level at all below the normal range, 0.1 or 0.5. Thyroxine therapy. The degree of thyroid suppression is dictated by balancing the risk of recurrent thyroid cancer and subclinical thyroidotoxicity, particularly the cardiovascular risks. Surveillance. Looking at the BRAF mutation detection of thyroid cancer in FNAB samples demonstrated a 100% specificity and sensitivity in causes of PTC carrying BRAF mutations. Medullary thyroid cancer. There are tumors of parafollicular C cells which produce a hormone called calcitonin. Types of medullary thyroid cancer, or we can call it an MTC. Sporadic MTC medullary thyroid cancer and familial medullary thyroid cancer. Men to A, men to B, familial non-men. So you can see here clinical and genetic characteristic of familial medullary thyroid cancer syndrome. Clinical presentation. Sporadic middle thyroid cancer, asymptomatic thyroid mass, familial middle thyroid cancer, screening stimulation test for calcitonin or with molecular analysis, detection of red gene mutation. Treatment of sporadic medullary thyroid cancer. These cells do not concentrate iodine, so radioactive iodine is of no value in their management. Surgery is the only definite therapy of medullary thyroid cancer. Total thyroidectomy, central node dissection, ipsilateral modified radical neck dissection. So you can see here the presentation of medullary thyroid cancer. Tumor adhering into the chest wall. Anaplastic thyroid cancer. The woman with anaplastic cancer of the thyroid. Here the epididymal scan. So you can see here the large anaplastic tumor, which moves trachea and esophagus. Treatment of medullary thyroid cancer based on the genetic test for the mutation of RET gene. Since different mutations in the RET gene are associated with variable disease aggressiveness, this leading to individualized treatment of patients with inherited medullary thyroid cancer. Anaplastic cancer of the thyroid. This is a very aggressive tumor with a poor prognosis. A female-to-male rotation 1.5 to 1, and the mean age is 67 years. It is commonest in areas of endemic goiter where there are chronic iodine deficiency. It is commonly related to prior diagnosis of well-differentiated thyroid cancer. Clinical presentation. So the clinical presentation, long-standing goiter that suddenly increase in size. Local invasion lead to obstructive symptoms, hemiptysis, diaphysia, and Hirschness. At the time of diagnosis, 25 to 50% of patients have syndromus pulmonary metastasis. Surgical treatment of atypical thyroid cancer. In the majority of cases, surgical is limited to an open biopsy to exclude lymphoma. Radiotherapy and chemotherapy. External beam radiotherapy (EBRR) has been used with limited success to treat local recurrent ATC. Doxorubicin is the simple, most effective therapeutic for ATC. Thyroid lymphoma. Thyroid lymphoma is a relatively rare disease, constituting less than 1% of all lymphoma and accounting for 2% of external non-Hodgkin's lymphoma. Male rotation from 3:1 up to 8:1. Median age is 7th decade of life. Clinical presentation. Local invasion, hoarseness, dyspnea with stridor or dysphagia. Hypothyroidism in case of autoimmune thyroiditis or Hashimoto's thyroiditis. Primary treatment should be EBRT combined with chemotherapy regimen based on histopathological subtype of lymphoma. So thank you for your attention. Goodbye.